Welcome back to Decode Healthcare with Harshal. Today's explainer is a deep dive into the strict, constantly shifting rules of telehealth EM coding. We're going to break down exactly how to ensure you get reimbursed correctly, and more importantly, how to dodge those dreaded audits. Virtual care is obviously a massive part of modern healthcare, but man, the coding guidelines are incredibly specific. So if you're a coder, a biller, or a healthcare provider, this is absolutely essential knowledge. Let's jump right in.
Here's our roadmap for today. We'll start with the Telehealth EM framework, move into place of service mechanics, essential telehealth modifiers, audio-only coding rules, distant versus originating sites, and finally, top audit red flags.
Section 1. Telehealth EM Framework. Synchronous versus audio only. Let's hit it.
First things first, what exactly is synchronous telemedicine? Basically, it means it's happening live, right in real time. It's a live, interactive encounter between you, the provider, and the patient. It essentially takes the place of an in-person visit when it's medically appropriate. Now, just calling a patient to say, hey, your lab results look great, yeah, that doesn't count. We're talking about true clinical evaluation and management here.
This breakdown of the CMS classifications is super helpful. Your standard office and outpatient EM codes, that's 99202 through 99215, are your go-to for live two-way audio-video visits. But as you can see, there are also entirely distinct buckets for audio-only, asynchronous store and forward, and remote patient monitoring. Figuring out which bucket your specific service falls into, that is literally step one for compliant billing.
So how do we actually choose the right level for those 99202 through 99215 codes during a virtual visit? Well, just like an in-person office visit under the modern AMA guidelines, your code selection comes down to one of two things: either your level of medical decision-making or the total time spent by the provider on the date of the encounter. And remember, you got to pick just one basis per encounter. They are completely mutually exclusive for that specific visit.
Moving right along to Section 2, Place of Service Mechanics, POS 02 versus POS 10.
Think about this. Where is your patient sitting right at this exact moment? If they're chilling on their couch at home, you use POS 10. But if they're taking your call from their office on a lunch break or maybe at a local clinic, you have to use POS 02. It is absolutely crucial to differentiate where the patient is physically located during the service. Private residence or temporary lodging, POS 10. Anywhere outside the home like a hospital, workplace, or school, POS 02. Now, why does this two-digit code matter so much? Because POS 10 is the default for most CMS and commercial payers for virtual home visits, and it typically reimburses at the higher non-facility rate. That's basically the equivalent of an in-office visit. POS 02, on the other hand, reimburses at the lower facility payment rate because the payer assumes the facility is handling some of the overhead costs. Honestly, getting this wrong means you're either leaving hard-earned money on the table, or worse, you're risking an overpayment audit.
All right, Section 3, Essential Telehealth Modifiers.
Let's equip you with the exact modifiers you need to tell the full story on your claims. Modifier 95, that is your gold standard for video. Modifier 93, that's strictly for audio only. Do not mix these two up, guys, because they trigger entirely different payer rules. You'll also see GT and GQ, which are mostly for institutional claims. And a quick side note, if you're billing for a federally qualified health center or rural health clinic, you'll need modifier FQ for their audio-only telehealth services.
Let's actually put this into practice. Picture an established patient doing a video visit for hypertension from their living room. You'd code a 99213, slap on modifier 95 for the video, and use POS 10 since they're at home. But let's say it's an audio-only depression follow-up. For that, you need an audio-specific code, and you'll append modifier 93. Pretty straightforward when you break it down, right?
Let's jump into Section 4, Audio-Only Coding Rules.
Billing for a simple phone call has an incredibly strict set of clinical criteria. If video isn't available, you absolutely can still bill for an audio-only EM encounter. You'd use the standard EM codes with modifier 93 or the dedicated audio-only codes. But the medical discussion must exceed 10 minutes. And here's the major catch. Your documentation has to explicitly state why video wasn't used. Did their Wi-Fi drop? Do they just not own a smartphone? Or did they flat out refuse to turn the camera on? If that why is missing from your notes, your claim is a sitting duck for auditors. Plus, your documentation still has to meet the full MDM or time requirements exactly as if they were sitting in your exam room.
Now, what if the video connection just completely fails mid-visit? Providers ask me this literally all the time. You start a video call, the Wi-Fi crashes, and you end up finishing the whole visit over a regular phone call. How on earth do you code that hybrid mess? Well, CPT guidelines give us the majority of time rule. Basically, you report the modality that took up the majority of the interactive portion. If you spent 15 minutes on video and just 5 minutes on the phone wrapping up, you bill it as a video visit with Modifier 95. But if you spent 2 minutes staring at a frozen screen before switching to a 20-minute phone call, you bill it as audio only. Just remember that audio-only portion still needs at least 10 minutes of clinical discussion to be billable.
Section 5. Distant site versus originating site fees. This concept causes a massive amount of confusion. So let's clear it up. The distant site, that's you, the billing provider, wherever you're sitting. The originating site is exactly where the patient is located. When you're billing for professional services, you have to use your usual location for the distant site. Now, if a patient travels to a rural clinic just to use their equipment to video chat with you, that clinic can actually capture their own facility fee using HCPCS code Q314. That covers the telehealth originating site facility fee.
And a quick special note here. If you happen to be billing for a rural health clinic or a federally qualified health center, those standard rules often just go right out the window. You actually have to bypass the standard professional E&M codes entirely and use specific G codes, like G2025 for telehealth encounters, to make sure Medicare reimburses you properly.
All right, Section 6, Top Audit Red Flags and Billing Compliance. I like to call this the boss battle of medical coding.
Let's highlight some instant red flags. Using an in-person POS 11 for a virtual visit, that's an automatic denial. Appending Modifier 95 to a telephone encounter, denied. What about billing time-based codes without documenting the exact start and stop times, or at least the total time with a clear breakdown of what you did? Yep, prepare yourself for a manual review.
To keep yourself out of hot water, run through this compliance checklist every single time. 1. Always make sure your note clearly states you got patient consent. 2. List the actual platform used. Don't just write video, write Zoom for Healthcare or Epic MyChart. 3. Document the exact physical locations of both you and the patient. 4. Double-check that your POS and modifier combination makes sense. And finally, never double bill originating site fees or bill phone codes for calls related to an EM visit that happened within the last 7 days.
Ultimately, guys, the golden rule of virtual care is this. Remote visits do not mean reduced documentation. Your note has to reflect the true intensity of the care, exactly as if that patient were sitting 2 feet in front of you. So think about this. If an auditor pulled your last 5 telehealth claims right now, today, would your documentation prove the patient couldn't use video? Or would you be writing a refund check? Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.